Okay. So I'm Dr. Franklin, and I'm going to be presenting about the treatment of tics, and in particular CBIT, the Comprehensive Behavioral Interventions for Tics. I actually worked on the CBIT trial, one of the CBIT trials for NIH. I was a research assistant. This was, 15 years ago. But it was very interesting to see it in action. I say this is one of the few things where you can see your clients, you can see your patients getting better, which is kind of really amazing to be able to like visually see it. Okay, so I'll just dive in. I guess that's a little background about me. So just like a brief introduction. Most of you probably have watched the other trainings, so you kind of know, so I don't want to spend too much time on this. But tics are sudden, repetitive movements or sounds that can be difficult to control. They're semi-voluntary or involuntary. We like to kind of stay away from calling them completely involuntary, but also emphasizing that they are really hard to control. So they're not something that is in our full control, but they can be suppressed, and we can learn how to kind of continue to suppress them in a way using CBIT. Even suppress is like a difficult, word to use because we don't want to put it on the clients in any way that they're, just doing this or they're not trying hard enough. But we also want to kind of play around. I think a lot of people think, this is just like a movement that's completely out of control and no one can do anything about it. And so it's in this sort of gray area in between. So just the difference, tic disorder and Tourette syndrome, we use them a lot interchangeably, but tic disorder is technically you have either motor or vocal tics, but not both, and lasting at least a year. Tourette syndrome, you have both motor and vocal tics. So just some more stuff. I think the training's probably covered a lot of this, but tics typically start around age 7. So we see them in kids. And one of the things is they do have to start before 18. If you see them sort of come up after 18, we tend to think maybe something else is going on, but it's not unheard of. It's just less likely. Most people will see them in childhood. Tics are relatively common in children. So probably 20% of school-age children have tics at some point in their lives. Most of these are mild and might not even know that they're tics. People are like, oh, that's just a quirky thing they're doing. A lot of times it's sniffing, or maybe coughing, sometimes even speech things where they're maybe, mispronouncing a word in a way or something. People might not even notice that can be a tic. So a lot more people have tics than we realize. And most children will outgrow these tics. But it's estimated that people with tic disorders who have these tics, for a year, probably 1% to 2% of the population. And I think that is what happens when they stay into adulthood. So a lot of kids will have them for a period of time, outgrow them. Some people will have them and they'll get more significant and may persist into adulthood. Okay. Let's see. So this is just if you want the diagnostic criteria, but I don't think that's super important. So here's just a list of simple and complex tics. Again, we use lots of different words. You don't really need to know this. Simple are just usually that's like the basic movement. But sometimes we can get these more complicated tics that are kind of built upon the simple ones. So the simple tics like eye blinking, eye movements, this could be any sort of muscle movements. Those are just like very like one movement. But then we get some that are maybe like more, it looks like planned out. This is where it looks like more behaviors, where someone maybe, walking back and forth in a certain way, touching things, where it looks more planned. We would call that a complex tic. Sometimes they start out as simple motor tics and then they get more complicated. So something like I knew someone who had an eye blinking tic, and then it became, okay, I have to blink all the corners of the room. And then after I blink all the corners, I have to clear my, so sometimes they just get added on and they become these more complex tics. I don't want to spend too much time on this. This is the same thing for vocal tics. We can have just noises. I think coughing, throat clearing, sniffing. Animal or bird noises are more common than you would think. So sometimes it's just like that kid likes to make, roaring sounds. And it's like that can actually be a tic. So complex phonic symptoms, this is where I think there's a lot of stigma. People really associate it with this corporalalia, this obscene words. And that's maybe not the most common or rare, and I feel like it sometimes gives people with tics or Tourette's a bad name, but that doesn't mean that this does happen. You will see this. I got called when I was a research assistant, some terrible names by a very sweet lady. And it's usually like, this would be the worst thing I could say right now, and that's the only thing I can think to say, and I feel like I have to say it. Echolalia, where we have people repeating other words. And this is where I think sometimes it's important to recognize when these could be tics, because they're sometimes, I think, diagnosed as like stuttering or speech impairments when it can actually be a tic. It's blocking is when like I'm interrupting a word. I feel like I can't quite get it out, and that can be more of a tic. So sometimes just being aware of what that looks like, because I think a lot of people aren't always familiar with that, can be a presentation of tics. Okay. So conditions co-occurring with tics. We find that 50% of people also have ADHD. 30 to 40% also have OCD, and there's a lot of other impulse and behavioral problems, just a lot of impulsivity. Sometimes we see anger, and I'll go into it in this next slide. So this is where I like this diagram from the Tourette Syndrome Association, and it talks about maybe all these other sort of things that we see. So some of these executive functioning difficulties, rage. Sometimes you'll see kids with tics, they're also more prone to what we call these kind of like rage attacks, which sounds extreme, but where they get very angry, work themselves up for like 30 minutes, like a tantrum, and they can't get out of it. And it's really just that their impulse, their brake system makes it very hard for them to regulate some of these emotions too. So that can go along with it. So to kind of know just all the different things that you see. It's all sort of a spectrum in here, but I think you probably saw that with some of the other presentations. So one of the most important parts of learning about tics is the premonitory urge. I've heard it called premonitory, that's how I pronounce it. Other people, sometimes I've heard it premonitory, sounds fancier that way, but I call it the premonitory because you're kind of monitoring it and it comes first. So these are sensory phenomenon or physical sensations that precede tics. They're described as uncomfortable bodily sensations, a sense of inner tension, feelings of incompleteness, or extra energy. Sometimes they're described as an itch, tickle, muscle tension, like holding in a sneeze. Engaging in the tic then relieves that uncomfortable sensation. So this is a diagram you'll see in a lot of the papers that they write when they're discussing them, which is kind of an interesting diagram, but it's this idea of where most people experience it, where to kind of be on the lookout for them. And we actually find that tics usually start in the head. You'll see people start with eye blinking, sniffing, throat clearing, and then they start to, as the disorder progresses, move to the rest of the body. But so we find that a lot of people experience this, premonitory urge in this area. That's where it's most common. Okay. So just another slide about this to kind of understand that cycle. I like this diagram. You have that the premonitory urge. You experience muscle tension, motor, sensory activation. You perform the tic, you get relief, and that sort of continues the cycle by reinforcing it. So similar to our anxiety cycle, it's not that different. I think a lot of people are intimidated about treating tics because it feels like, oh, it's this neurological thing, it's so complicated, but really we can boil it down to similar to how we would treat anxiety. So there's this urge, muscle tension, you do the tic, you feel better, but that perpetuates it in the sense that it's kind of continuing to reinforce that when I feel that urge, I need to do the tic. So here's just a description. James Leckman is a researcher, so I think this is probably one of his clients who said it, but I guess it's sort of an aching feeling in a limb or a body area, or else in my throat if it precedes a vocalization. If I don't relieve it, it either drives me crazy or begins to hurt, or both. In that way, it's both mental and physical. So there is some sort of mental component, but I'll get into that in a second. So just re-emphasizing, I like this diagram to kind of understand the differences and similarities between tics versus OCD. So with tics, we have this premonitory urge, the tic, you get relief, and then there's negative reinforcement that kind of continues the tic. Same thing with what we see with OCD. There's an obsession, there's anxiety, the compulsion, experience the relief, and then negative reinforcement. So this is something I made because this is how I conceptualize tics. And I really think they're not that different than OCD, and it's probably a spectrum where they start to intermingle. And I know we just all watched that Tourette's OCD presentation, and I think that actually kind of hints on that or touches on that, where it can kind of be this gray area in between. But this is how I like to think about it when we're kind of trying to differentiate between tics and OCD. And in some ways, you don't always need to differentiate, but just for you to kind of conceptualize, we have this sort of on the physical end where it's only this physical sensation where they'll say like, yeah, it just itches and I feel like I have to do the thing. Then there's a sort of cognitive component or more fear-based where it's OCD, where you have someone in true OCD, like, you know, I'm having a fear of getting sick, cognitive, I'm feeling anxiety, and I do a compulsion by washing my hands. So that would be more on the OCD. But then we have this sort of gray area where we have like, it just doesn't feel right, which can be kind of like a tic. Like there's something inside me that it doesn't feel just right, and I have to find that feeling. I don't necessarily have a thought around it. So it may be somewhat similar to this tics. So kind of understanding that. When I'm treating someone with this, as I'm starting to assess, I might ask them certain questions to kind of get a feel for where this is falling. So even when they have pure tics, sometimes there is a cognition related to it, kind of like this physical sensation will never go away. This physical sensation is unbearable. So it's not just, I'm just responding to the tic. There's also a bit of, you know, a little bit more of that anxiety in the sense that I'm experiencing this discomfort and I have kind of a thought about it. Sometimes people will have a tic, but then it starts to veer into OCD where it becomes a superstition almost. If I don't do the tic, this bad thing will happen. Sometimes the bad thing is like, it'll never go away, but sometimes this bad thing, like I feel a sense of doom, like I will have bad luck the rest of the day. I will ruin my day. Sometimes it can be then really more OCD. If I don't do the tic, you know, my grandmother will die. That would be an obsession, but it started kind of with this feeling, this physical sensation, this sort of tic. So kind of understanding that. So when I'm assessing, I ask like, okay, when you do this, if you were to not do it, what would happen? And people with tics will say, it'll just get really uncomfortable and like, I have to do it. Then you might hear this like, it wouldn't feel right. And I would feel like I would keep thinking about it until I did it. We get sort of in that more just right. But then we get, if you have people describing that fear, then you might need to start conceptualizing it within also that OCD sense of it's got a compulsion feeling. This can affect treatment. Again, treatment is actually very similar, but it's good to kind of just get that information. So I usually ask, what would happen if you didn't do it? Are there any thoughts related to it? Do you feel fear? People with pure tics will kind of just say, nope, it just feels uncomfortable. Okay, so that was a lot. Now getting into CBIT. So comprehensive behavioral intervention for tics. CBIT, also known as CBIT, approximately 40 to 67% of children have reported partial diminution of their tic symptoms when treated with CBIT. Approximately 38.1% of adults were considered improved after CBIT. This was the study that I worked on. There is increasing evidence that CBIT is effective as medication, but with fewer side effects and should be considered a first-line treatment. So yeah, the medications work, but we find that CBIT is probably just as effective as the medications. And a lot of the medications that really are prescribed, they've got some newer ones now, but the ones that have been most effective have terrible side effects. So it's like we really would prefer to use CBIT first as the kind of first line treatment for tics. Telehealth is just as effective for delivering CBIT as in-person therapy. And so I have to do a little self-promotion shout out. So I was one of the authors on this study. But I think sometimes people think like I have to come into the office to do it. And in some ways, I find that telehealth for some people can be easier because they can be watching themselves. So if they're doing tics, it's like they can also see it, especially if they have facial tics, because sometimes you're not always aware that you're doing it. So having that, you see yourself in the image can sometimes be helpful. So more CBIT. I find, again, I think people are very intimidated by it. It sounds fancy. It's got a lot of fancy names. And I have a book that I really like. And one of the quotes in it is, if we don't have impressive sounding names for things, no one will take us seriously. So I think people are probably very intimidated by this treatment because we've come up with these like really complicated names and it's this, highly scientific thing. And I don't think that actually has to be that way. I think that's creates buy-in, gives us this important sounding thing, maybe is intimidating to therapists, but I can actually break all these things down and it's not that complicated. The main component of CBIT is this habit reversal training, which really is the treatment. They changed it to CBIT, like we're doing HRT, which you probably learned about with TRIC and other things. But they really hated this idea that habit was in the name of it. I mean, this was created in the 70s and it was for a bunch of different behaviors because it gives this impression that kids are just doing a bad habit versus this is something we want to, it's a comprehensive behavioral intervention for tics. So you don't actually need to know all of these components. I'm just breaking down what they are. And you can go back to that, refer that, but really we're doing HRT. And so this is the way, it may not be exactly how it's, in the manuals or how other people, this is essentially how I conceptualize it and boil it down, that these are the parts to CBIT that you're doing. You're doing psychoeducation, awareness training, self-monitoring, and then competing response training. And they will talk about social support, but I'll go into that. I don't think you necessarily need that. Really, we just need that competing response training. So psychoeducation. The goal of psychoeducation is to reduce blame, stigma, negative feelings related to the person's symptoms. Psychoeducation gives a metaphor or framework for understanding tics. And so I was actually working with someone yesterday with tics, and I wasn't going to make a slide about this, but now I'm realizing I probably should. It might have been helpful. So I can do an additional slide and maybe, video 5 minutes to kind of go into it. For next time, I just didn't have time. And I realized after meeting with this client, I was like, yeah, for some clients, it can be helpful. So kind of just going through other people who have tics reduces the stigma. And then the brain genetics, I think, again, this is the thing I don't normally think is important. I don't go through with every client, but for some clients, it is really helpful. And it does give them okay, this is my brain doing it. But I also think there's a lot of kids who are I don't care. I don't understand this. Why are you showing me this? Then occasionally you'll get someone who's I know more about the brain than you do, and you don't seem to understand exactly how these things are working. And I'm yeah, no, you do. I'm oversimplifying it. So I'm you don't need all of this, but sometimes it's helpful. It can create buy-in to be this is your brain. Your brain is doing this. It's not you. Just a lot of kids have shame, especially if they have tics that maybe parents didn't realize were tics, where they were why can't I just not do this thing? So these are some of the metaphors we use, calling them brain hiccups. It's a brake system in the brain that needs a tune-up, or mosquito bites or an itch that you just want to scratch. The metaphor I use, because I'm I still can't figure out, I'm bad at using, strategies for when my nail polish starts to chip. I'm oh, I just gotta scratch it off. I just can't not. It's as soon as it's there. So we all have that thing that's sort of it just becomes really difficult to resist. And I think helping parents understand this as well can be really important. This is an itch that they can't, just saying, if you had a really itchy sweater all day on and you're just so uncomfortable and you're oh, I just need to go scratch in there. Or on a cast, I just need to get in there and scratch it. that helps the parents understand, like, this is hard to resist. They're not choosing this, it's difficult. So to the next slide, I was playing around with AI because I always focus on the wrong things when I'm making presentation, which is kind of, well, meta, which gets into our next thing. But I was doing this, and then one of the things that came up was this picture. And I was like, again, this is so meta for my car thing, because like, what is this? What is this random cute little thing? I put in the AI, like, you know, dashboard, car, cartoon, brake, accelerator. And I get this. And I'm like, that's actually a great metaphor for tics. It's like, we have, sometimes people, you know, they have a brain where it's just going to give you this random thing. It's like, most of the time our brains are like, this is the thing that we need. And then sometimes we get, you know, a random bunch of, I don't even know what these little things are that make no sense. So I was like, wow, that's kind of perfect for explaining tics. So I will sometimes, you know, tell kids that your brakes are slow and the gas pedal and the steering wheel are super fast and sensitive. And sometimes our brakes don't have time to catch up. Sometimes random spam, like, you know, spam gets through the brain that normally would be stopped by the brakes, but our brakes just can't stop it in time. And so again, if I do that other, you know, brain thing, I was thinking about how I could explain it. If you think about, like, if you have to catch a baseball, your brain has to, okay, I hear the ball being hit. I'm seeing it. I have to like judge. I have to run back a little bit. I have to like put my glove up. Okay, I'm feeling where it is right there. I've caught it. I feel it in my hand. I close my hand, take it out, throw it. Like, there is so much that goes into that. And part of your brain is just sending like millions of signals. Like, okay, these are all the options that you could do. Like, just like a bunch of them. And then there's another part of your brain that's like, okay, you figure out which ones are important and which ones to let through. And that's the part where people with tics, they're getting all these things, and some of the like random ones are just getting through. And that's kind of how we think about it. So I hope that was helpful, that metaphor, but we can go into that a little bit more. That's all that's really going on. And I'm sure someone who really knows neuroscience would say like, no, it's much more complicated. Like, it's got more than that. But this is how I think of it for explaining it to kids. So the next step, did I feel that? Okay, yes, awareness training. Here's a tic hierarchy. Again, in training, they teach you to do this. I actually don't think you need to do this, but if you want to follow the manual kind of per se, you just gather a list of all their tics. You create a hierarchy with the most intense or disruptive. I will usually just ask them like, what tics are going on right now? Which one, you know, would you like to work on? We don't necessarily need to get all of them every week, but the manual likes to be very specific and manualized, and so it'll have you have this list. But basically, you're just asking them, tell me what tics you do. Tell me which ones are maybe the most disruptive for you right now. Okay, this is the part that I think gets more important, the awareness training. So I say we're being tic detectives. We're trying to really figure out what's going on with the tic. And we want to get super specific. So describe the tic in detail. Go through each step. You can have them reenact the tic. So a lot of times these things are very complicated movements that they haven't actually thought through. You know, they're just like, I just do this thing. So I had a client I'll use as a case example later, but as she's describing the tic, she's like, okay, first I feel this like bubble in my stomach, that it just feels like there's extra air in my stomach, and I have to stretch out my stomach. So I stretch it out, and then I press in, and then I have to move. So I won't go through the whole thing, but she's going through each individual step. And that's important because sometimes when people are like, I just make this movement. And it's like, no, if we break it down, we actually see there's all these little movements in between. And helping them to kind of get more insight into this helps them to maybe more detect that premonitory urge. So this is where you're asking them to also start to think about what warning signs, what feelings do you have before the tic? A lot of times, like I had an adult client who'd never heard, and he had pretty significant tics. He was like, I'd never heard anyone give a word to that premonitory urge. And he was like, that is so powerful to have a word for what that is. Cause he was like, I just sort of have to do this thing. But now he's like, actually, I feel it here. This is this feeling that I have to relieve, but I never knew how to kind of describe that or what that was. So asking them to think about it. So sometimes with kids, they don't always have that insight. I think everyone has that. There's some debate in the field where everyone has the premonitory urge. I think they do. I think sometimes people just aren't always aware of it. I'll get back to that. But where and when do they happen? Do they happen at school, when watching TV, in the car? Are there emotional triggers? Are you bored, anxious, etc.? Are you less likely to do them in front of others? So this can help people know, like when people are like, I can't stop it, I just have to do it. What we'll find is a lot of times kids will be like, well, if I'm in front of my friends, I'll like do them less. I won't do them as much. And that can help them. Again, we're not blaming them or saying that they have control, but we're saying that okay, wait, so if you don't do them in these situations, like tell me more about that. And that's where they can start to see like, yeah, I am able to sort of suppress them for periods of time, helping them to get that insight. A lot of kids will say like, I feel like I'm holding them all in and then I get home from school and I just have to like do them all. A lot of times a big trigger is they're tired. So they have been suppressing all day. And then when they're more tired, they come out. So that's part of this, like being tic detectives, getting as much information about the tics that you can. Let's see. So now I'm going to self-monitoring. So this is where we want them to start to monitor, because a lot of times they may not know, they may not be doing the tic in session. So it's hard for them. They're like, I don't know how it feels. I don't know what comes first. So you're asking them, when it does occur, can you start to monitor, like where and when? Again, this is the sheet, that they use for in the workbook. This is like the official one. You don't have to use any of these, but this is just an example. So I know this is probably the thing that confused people most in the training that you watched, where they were talking about how can we help signal to people? How can we sort of help kids understand when it's happening? And I think you just start with, can they monitor it? Can they start to be aware of it? If they're not able to, this is where then we can start to support them in getting them to be more aware. And the way we do this is we start by having a signal. So the signal, the default one we normally use is like, okay, I'm going to just put one finger up when I notice you having a tic. They have to be open to this. Sometimes they're like, oh, I don't know, that doesn't feel okay. And we respect that then. But most people are like, oh, I'm okay with this signal. Some kids are like, I don't want this because that feels like, you're judging me or something, because we may ask parents to use it. So, help come up with a signal that's acceptable to them. Once you have that signal, so if they are doing it in session, like I'll see someone who's maybe not aware that they're scrunching their nose or doing something because it happens so frequently, or they have just learned to kind of ignore it. By giving them that signal, it's not to judge. I say we're not judging, we're just trying to let you know when maybe you're doing it. As they become more aware of when they're doing it, they start to have more insight into that premonitory urge, or they start to notice it more. So awareness training, the self-monitoring, can help them kind of make that connection. I know in the training, they're like, they want the kid to start noticing when they're doing it. I don't usually do this. This is more like if you really want to take it to the next level, you can have the kids start to signal when they start to feel it, or when they've noticed they've done a tic, and then to start to see if they can catch it beforehand. So that is all that really is. I know that was like a complicated thing, but you're just asking them like, hey, when you notice you've done a tic, I've done this. Now I'm going to have you just, notice when you're doing a tic and see if you can catch it beforehand. Most of the time, you don't need to go there. You're just asking them to monitor and start to pay attention to what feelings they might feel. So I just wanted to kind of demystify that. Competing response training. So this is sort of the like meat of the therapy. This idea that what we do is we're going to train them to use a competing response. So the competing response is a behavior the person can engage in when the urge to tic appears or soon after it starts. Again, we want them to do it beforehand, but if it's starting and then they can do it in the middle of it, even afterwards, we're hoping then over time they're going to start to catch it beforehand. So for a competing response, again, fancy word for, I say, you know, competing responses are just kind of like, just block it, just do something that blocks it. It's a fancy term, but it doesn't have to be. We're just coming up with something physically incompatible with the tic. It should be something that can be maintained for at least a minute or until the premonitory urge goes away. So like holding your breath is not a competing response because I don't know about you, like I don't think I can make it a minute. That would be hard. So it needs to be something that I can hold for at least a minute. We also want it to be socially inconspicuous or compatible with normal ongoing activities. So if it's something like where you would have to stand up, you wouldn't want that to have it in the middle of class that a kid has to now stand up. So you want to find something that's going to be workable for a bunch of different situations. Like standing up may be something that you can do at home to use as a competing response or when they're in an appropriate setting, but we want to find something that's not going to draw more attention to them. And it should include feedback from the person about what works best. Like oftentimes we don't know, they're going to know, like actually this like, you know, tweak is what's going to really work. So have them help you. Like, what can you do? Like, if you were to do this, can you still do the tic? And I'll go more into this in a little bit, but work with them. Sorry, this is another slide that I think even makes it simpler. I stole this from someone else. So remember, a good competing response is the opposite of the tic. So it blocks the tic. Is less of a problem than the tic, for example, less noticeable or less painful, and can be done for at least 1 minute or until the urge to tic passes, whichever is longer. So here are some examples, and I'm going to spend kind of the end going more into them and like more comprehensive list of how to figure out which ones to use. But here is some examples. So eye blinking and throat clearing are usually actually some of the hardest ones to treat. Most of the time with eye blinking, I'm like, people are like, it doesn't bother me that much. We don't even need to treat it. But there are ways if it is something that's bothering. And it's the smooth, controlled blinking, or if needed, focus one spot on the room. But the more common ones here, so like head jerk, head movements, so you're kind of tensing your neck. Maybe you need to push your chin down. So I have a client who he's holding his head back because his head normally goes forward as the first thing. So he's kind of holding it back in a way that's not super obvious, but he's tightening the back of his neck. You know, shoulder shrugging, it's really you're keeping your elbows toward the hip. Hand finger movements, you know, if you're holding your chair or if you're making a fist. So it's this kind of idea, whatever. I'll go into more detailed. The vocal tics, these ones are hard in the sense that you're doing just controlled breathing. So you want to make sure that you're trying to do it opposite of the tic. So if someone has a sniffing tic, normally we tell people, you know, breathe in through the nose. We would want them actually maybe to breathe in through their mouth so that they're not using that sniffing tic. So breathe in through your mouth, and you can do it through your mouth, or you could exhale through your nose. Again, work with them to see what works. But it's kind of like you're playing around with this. And I think it's confusing because in diaphragmatic breathing, we're usually like, breathe in through your nose. And this time we're like, maybe don't, actually do it the opposite. So that's something to just work with them to see how does it make it harder or incompatible, like you can't do the tic. For vocal tics, oftentimes we're telling them just keep your mouth closed and breathe in and out through your nose, like slowly, and wait for that urge to go away. Can be a little more complicated to that because they may still need to be talking, but I'll get into that in a second. So again, for phonic tics, these are these vocal tics, slow, regular, deep belly breathing through the nose with mouth closed, like I was just saying. I kind of like this, picture breathing in, breathing out the urge to tic, or picture breathing out the tension in your muscles. So this idea when you're dealing with that urge, just practice kind of breathing out that urge. So this, you know, table suggested part lips, breathe slowly, regularly, and deeply through the mouth. You're breathing through the mouth and not, the nose where it's going to be easier to sniff. Okay. So this is where, I don't know if I can switch tabs to show you. I have a list. I'm going to click on this. Let me know if you can see then what I open. Do you guys see that too? You don't see it? You're still on the, okay.
You just have to switch your sharing at the bottom. You're just showing this tab, but yeah.
Okay, wait. So I'm going to stop sharing for a second and then reshare a different tab. Again, I love my technology. So I created this and I'll work with Lisa because I put it in my folder just to make sure that everyone has access to it. So I can update that link. But this is where I have put just a couple different resources together that has like a catalog of different competing responses. So this is the one I stole some of the images from. And we can go through this more later, but just so you know, there is a resource for this that has different suggestions for different tics. So I like this one. I threw this table, I kind of combined a bunch of them. And then this is the like sort of official manual, has a list of ideas for competing responses. Again, you don't need to use any of these particular ones. You're working with the client to kind of figure out what works for them. So there's no like this is the correct competing response. It's really you figuring out what works with the client. And then I guess while I'm here, let me share the other resources that I mentioned in my PowerPoint. Okay, let's see. So this we have on the drive, which is the actual therapist manager. So this is already exists on the drive, the therapist guide, and it breaks through. So one of the lists I took was from there, but you'll now have a cheat sheet to get straight to the list and you don't have to look through this whole thing to find that. So this gives you more information about everything and all the steps to do the treatment. Again, I feel like you don't need it, but if you want to go back, you have that. And then the last thing is, because they love to get you to buy multiple things, they have a therapist guide and then they have the workbook, and we don't have the workbook. They have a kid and an adult workbook, which is essentially exactly the same, with just the adults have not parents. So I love that they're like, oh, here's the adult one, here's the kid one, and here's the therapist guide. But anyways, so there is a link to the forms, because really all you need for the workbook is just the different forms that you can use. You don't have to use these forms. They're not super fancy. These were designed for research studies. They're not necessarily the most like fancy or like, maybe aesthetically pleasing forms, but they're forms, the ones that you can use if you need them. So let me share that now. Let's see, and this link should be in the slides here. So if you go to the book, so this is the parent workbook, and then it'll have I don't know if you can see this, like if you wanted the tic hassles form, can you see that? Yeah, I don't even use most of these. Like the ones I might use is you have the tic, this is where I got the tic hierarchy. And you might use the monitoring sheets. But if you wanted to actually go through the real protocol and use all of that, here's the forms. And I don't think you even need to use them, but you have that option. Some of them might be helpful as a guide. Okay, and let me go back to sharing. Okay, so we're back to here. So part of the competing response, start with the most disruptive or bothersome tic first. Typically, that's what we say, like, let's go with what's bothering you most and let's really work on that. Sometimes another approach can be, if that one seems too hard to work on, let's start with the easiest one to treat that has a very clear competing response. Because what you're doing is, okay, if this one is too hard to do, let's find one that maybe you're also doing that's pretty easy that we could work on. And once they see that they can use this competing response, they get more buy-in and are more likely to keep going. Sometimes that's all they need to be like, oh my goodness, like I don't have to do the tic. Like I had an adult who was basically like, it never occurred to me that I could like just not do it. That I could just like ride out this urge and the urge would go away and I like don't have to do the tic. And I was like, there we go, treat it. Like that's all he needed was like to understand that. So we're just trying to get them to see that because a lot of times they've never, it's so, you know, that itch is so intense and the motor movements happen so fast that they don't know that I can actually ride out this urge. So if we can get them to see that, they can start to use these things. So one of the things that I say that I don't think was emphasized as much in the training, maybe it was, but I say really practice the competing response throughout the day, even when you don't experience the urge. A lot of times, even if they can't catch it, the more you do it, the more likely you are to then be able to use it and catch it. So I'm like, even when you don't have the urge, let's just practice. We're now just strengthening this habit, this sort of, you know, I shouldn't say habit, but this alternative behavior. We're practicing doing this, and then maybe eventually we'll start to be able to use it when we're experiencing the urge. But we're really strengthening that my brain knows how to do this competing response behavior. So you have them practice holding the competing response for at least 1 minute. And I say 2 to 3 times per day. If you can do more, awesome. I think 2 to 3 times is usually what people are most likely to be willing to do. So I'm like, hey, let's find a time in the morning. Let's find a time at night. Schedule that. When are we going to do it? Can we hold it? Can we do it in session? I will have them in session where, again, it feels very boring, where I'm like, we're just holding this. I've set my timer. We're just going to hold this. You know, I guess you can't see me. We're just going to hold this right here. Like I'm talking to them. I'm like, yep, we're just holding it, practicing that we can do this. I'm like, breathe through it. But we're just getting used to them using that competing response, even when they don't have the urge. And so one of the metaphors I use, or one of the things I say, it'll be easier to use when you're experiencing the urge, the more it's practiced throughout the day. I have a forest pathway metaphor. But I also sometimes use a metaphor for sports, like, you know, we have to do drills. Like in basketball, we don't just like go and play a game. You do drills, you do things so that you're able to use these skills in a game. So you have to do it at times when you're maybe not under pressure to be able to do them under pressure. Like you practice shooting free throws just in practice so that you can then do it during a game when it really matters. So that's kind of the idea. We're getting really good at doing this, even if we don't feel the urge, so that then when we do, we can use it. So this is one of my metaphors. Again, I played around with AI. I love AI. It wasn't exactly how I wanted it, but then I was like, okay, I'm gonna go with this. This is the best one. Pathways in our brain are like pathways in a forest. So at first I say, like, we've got a really clear path that's been walked down a ton of times. That's our tic. Like our brain has just been like, hey, when I feel this, I do this thing. And that's like, I just go straight there. It's like, it just makes the most sense. That's what I do. But I'm like, what we're doing now is kind of clearing out another pathway. We're kind of going through a place where there maybe wasn't a path. And like, we have to get through, I have to like clear away all the brush. I sometimes say I've got my like machete and I'm trying to clear out the branches and I'm walking over stuff. And it's like, it's really hard to get through that first time. But the more we go down it, if I can keep going down it a bunch of times, that pathway is going to start to be more clear. And the more I can go down it and not go down the other pathway starts to grow over. And now I've made one. I'm like, this is the pathway we're going to go down. And that's where, with our competing response, we're going to use this one. That other one becomes, okay, now actually I don't need to go down that one. It doesn't make sense to go down that one as much. So I try and use that metaphor sometimes to help them understand that it's going to be hard at first, but over time, it's going to get easier. Okay, so here's a fun thing. After I've told you all that stuff about the competing response, here's a fun fact. Competing response does not have to be opposite. So it's really helpful, but you don't need it to be opposite. So the thing about it being opposite is that it helps kind of resist these habitual muscle movements. Again, but it's not technically necessary. I find with the people who have very quick, like their motor move, like it just happens, the tics happen so fast, they do kind of need it to be opposite so that they can prevent that like trained muscle response. But it doesn't have to be. So you can use another behavior like holding your hands together. So even if you have just like a throat clearing tic or something else, and you're like, I'm really focusing on holding my hands together. I realize you might not be able to see this. Well, I'm just going to focus on that. They're in my lap, and I'm really focusing on the feeling of my hands together instead of this vocal tic. So it doesn't have to be. Technically, you do not need the competing response at all. Again, I know, mind blowing. So I'm like, this thing that we just worked on, you don't even necessarily need it, but it's helpful to most people. So most people will find it much easier to have, I'm doing this instead, it's blocking the tic. But I just want to kind of demystify that, which brings me to my point is that when we say CBIT is this fancy hard that we're treating like neurological symptoms, it's this fancy behavior, I'm like, you're basically doing ERP. You're teaching the client to ride the wave and resist the tic, that urge, similar to riding the wave of anxiety and resisting a compulsion. So that's all it really is. Competing response can help interrupt habitual muscle movements and make it easier to resist the urge. Blocking the behavior is essentially a form of response prevention. So we do this even though in OCD, we're like, you know, it's best if you can just like sit with that and accept that feeling or whatever. But we're like, okay, we're going to shut off the shower at a certain point. So you get out of it. Like, I'm like, parents, like, shut off the hot water at a certain point because we're preventing the response prevention. So we do use that sort of in OCD to help people facilitate and get started. So it's that similar thing. Like ideally, I was like, if everyone was monks, they would just notice the urge and like resist it and be able to, you know, not even resist. They're just allowing it to be there and not engage in the behavior. But most of us aren't, and we need a little bit of help. But essentially, this is ERP. Another part of this is that you can deliberately expose the client to the premonitory urge and practice in session. So this is where there are certain things where people are like, okay, well, when I put my shoes on, I always have to do a tic. And I'm like, okay, let's practice taking our shoes off and putting them on. And then we can actually practice doing the competing response in session together. Oftentimes, if I have people talk about a tic, if they start thinking it, it's one of those things like, I'm not going to do it unless I'm thinking about it. Now I have to do it. So if we're talking about it, they're like, oh my God, all I can do now, I have the urge all the time. So just talking about it can be a way of exposing. I know David Sedaris had one of his books, he talked about how he had this tic where he had to put, like, I think his tongue, press his tongue against a window, and he stopped doing it. He's like, I don't know why I stopped doing it. And then my dad was like, hey, you don't do that anymore. And he's like, oh, now I have to do it again. And he was like, now that's all I can think about. Now every time I get back in the car, I have to press my tongue on the window. So it's one of these things where if we're not thinking about it, you might not have that urge, but as soon as we start thinking about it, it triggers the urge. But that can be a way for us to do essentially ERP in session. So I have my little ride the wave graph, which I stole from someone else, but then changed it to tics. So like, this is where you're trying to teach them. They're usually like, at this point, they're like, nope, got to do the tic. But we're trying to tell them, yeah, it's going to get worse. It's going to be hard. But if you can get through it, it will fall. And the thing about anxiety is anxiety can last a really long time. Like you can be anxious a pretty long time and you're like, I just need to do the compulsion. The great thing about tics, I mean, I don't know if it's great, but like what makes it easier to treat is that it usually doesn't last for more than a minute or two. It may come back, but a minute is usually all it lasts. So like they see that, oh, I can actually ride it out much sooner than someone with anxiety who's like, I'm still thinking about this for, you know, hours. And we're like, no, keep resisting. So someone with tic, yeah, the urge might come back, it might subside, and then they think about it again, comes back. But holding the competing response, they will see that that urge does go down. It gets really intense at first, but it falls. This is just that habituation, kind of what I'm saying before. So not only does it fall during when they're using the competing response that it becomes less, what we say is each time that you're doing it, it's going to, the intensity of the urge should be getting less. And as your brain is learning, I don't need to do that. You're breaking that reinforcement chain just the same way with OCD. And this is that sort of behavioral thing when a tic is performed. it reinforces that this urge requires action. So in our head, we're teaching our brain, hey, when you feel this sensation, you got to do this thing. And we're in treatment trying to interrupt that. So I think I needed to edit this, that this urge needs to be relieved with an action. Similar to OCD, we are breaking this link. As the tic is performed fewer times, like every time you're like, wait, to your brain, you don't need to do that thing when you feel that way. You're breaking that and it starts to learn, I don't need to do that. So the brain learns to habituate to the urge. The brain starts to pay less attention and not send the urge signal as strongly. So it's like, I don't actually need to feel like that's not important. Before it's like, yeah, this is important and you got to do it right away. But as we break that link, as we show them, wait, you don't need to do it, the brain is like, wait, maybe this isn't so important. Maybe I don't need to send this signal as strongly. So over time, the urge becomes less intense. And I think this is important to tell them because they think like, I have to do this every time I do a tic. Like this is exhausting. Like I'm not going to do this the rest of my life. And I'm like, no. If we can keep doing it for a couple of weeks, what you're going to see is that the urge goes, like that's the goal, is that you don't have this urge as much. So that's really kind of part of it, because I think some people are like, this is really hard. I want to feel like I don't have to do this the rest of my life. So some of the metaphors I use are like, our brain can learn to turn, like it can learn after a while with exposure, I can tune out unimportant information. So like that feeling of the clothes on your skin, that's one I say. I'm like, it's like, you know, if you start thinking about the clothes on your skin, it's like, yeah, I can feel them right now. I don't normally feel them. I'm not normally thinking about them. My brain has learned that's not important information. Similar to this, if we keep getting us to expose and not give it attention, we won't feel it as strongly. I use the cicada metaphor, like sometimes when you go outside in the summer and the cicadas are like so loud and you're like, oh my gosh, that's like so loud. And then you've been outside for 10 minutes and you like forget that you hear them until you start thinking about it. Like, oh yeah, they're there. Similar to this feeling, that urge, if we can start to just not give it as much power or attention or reinforce it, our brain will learn to tune out that urge. So the last kind of part of this with kids, you can do behavioral reinforcement. You can create a reward system for practicing the competing response. So I am always like, reward the competing response, reward its practice, reward for trying to use it in response to a tic. Never punish tics. It should never be about like you didn't use it. It should always be like, hey, you tried to use it today. Hey, you practiced it 3 times today. That's what we're really shooting for. You can also use rewards for like doing awareness training and self-monitoring. There's other parts of CBIT. Again, I don't think these are like hugely important. They just kind of added them on. Functional interventions. I will say sometimes the book talks about like attention being reinforcing. I don't like to go down that road, but it can be. We notice like they only do it in front of one parent. It's not like they're particularly seeking attention, but sometimes not giving it as much attention, ignoring it, can make the tic urge less intense. Sometimes we can reinforce instead alternative behaviors, know what emotions may be triggering it. Like boredom is a big one. Like we'll see people just doing it in front of the TV, which I'm like, if it doesn't bother you, who cares? But maybe it bothers other people and they're like, hey, you can't watch TV with us if you keep doing that. So maybe they are motivated then to work on it. And maybe we need to, if it's, this is that where when, like in front of the TV, okay, if you sit over here, you can't keep moving your arm because you're sitting in a way that's going to make it harder. If you're bored, can we use fidgets? Can we find other ways to deal with this? Yes, I know people have to leave. That's fine. It's basically the end. Sorry if I mistimed this, but I'm glad it was helpful. So tics are often mild, so you don't need to treat it. Like I had someone who's like, I want to work on these tics, and the rest, you know, he had, this is a guy with the, you know, there was a head one, and he does this one where he kind of goes like that. And I'm like, hey, if it doesn't bother you, you don't need to treat it. He's like, oh yeah, no, I don't care. Everyone in my life knows I do this thing. Like, and I'm like, the only reason we treat it is if it's bothering you or disrupting your life in some way. A lot of times parents are more disturbed by the tics than the kids are, and I'm like, the kid has to be motivated. This is hard. So trying to teach the parents, like, let's really support the kid and what they want. If they're not bothered by it, a lot of times they may not be bothered now, but what we're just doing is like starting to plant the seeds that like when you are, if this does become bothering, like you have these skill sets. Because a lot of times when they're maybe, 8 or 9, kids know I do this thing, but maybe as they get into their preteen years, they're like, oh, I'm a little more self-conscious now. Now I don't have that association of my parents, yelling at me all the time to work on this, but I know there are skills that I can use and that I can go to someone who can kind of give me that background, or I can use some of the things that I was taught before, even if I don't feel the need to use them now. Again, treating the ADHD or OCD is often something we need to focus on. Not everyone will benefit from CBIT. I think everyone really can. It's some of these ADHD kids that can be harder just because like they forget to use the computer. Like they're forgetting basic things like my backpack today at school. So using a competing response is not something that's going to be maybe high on their list. So that makes it harder. Doesn't mean it's impossible. So these are some of the questions parents will give people when they hear about CBIT, and I've just copied from the book. So I'm like, you can just read this verbatim off to them. But this idea that like tic suppression, like if they're just holding it in and it's going to have a rebound effect. And we're like, actually, we don't see that. Like if they're using the actual CBIT stuff, like they may have a rebound after school when they're tired and they're getting them all out. But if we're using the competing response, we find it goes down over time. Treating one tic will make untreated tics worse. Again, I don't have to go through all the reasons, but just if you have parents saying these things, you can combat this with evidence. This is a common one. Paying more attention to tics will make them worse. A lot of adults will say this, like now that I'm monitoring them, they do make them worse. And yes, temporarily, if you're thinking about it, it can make it worse. But a lot of times what we find is that then after it makes it worse, they start to get more awareness and then can use the strategies. So it's temporary. And also a lot of times people think it's making it worse. It's actually not. They're just now more aware of when they're doing it. So you'll find a lot of people who are like, yeah, I made it so much worse. I never did this before in session and now I'm doing it all the time. It's like, we're doing it in session. One of the funny things with adults will say, I never tic when I'm drunk, and their partner will be like, yep, you do. All the time. You just don't think about it or realize you're doing it. Because they're like, yeah, that's one of the times I never do it. So these are the measures. I don't really use the measures. You don't need to, but if you want to, they're there. That's what the research says. I don't know if they're that helpful. Normally it's just like, how intense are your tics? Like, how much are they bothering you? 0 to 10. That is the main one to really use, but they're out there if you want to use these measures. So I don't know, we don't probably have any more time. I can do an addendum maybe at some point, and we can go into more of like how to implement this, but if not, yes, don't have drop-in office hours, but you can always email me and I'm happy to talk about it.
Kind of did this, but if we were sharing with somebody that's new to light on anxiety, new to treating, you did such an amazing job comparing to OCD and normalizing this. Like, what would be the top, I don't know, like the top thing you would want to share with a new clinician who's here at light on anxiety that has never worked with tics before? And I'm putting you totally on the spot.
Yeah,
if I were to steal your wisdom.
It's so intimidating, and this is not rocket science. That we're using a lot of fancy words and that we're using a lot of like neurobiological things. And I think people here, we're treating a neurological condition, we're treating something that people think is like uncontrollable, and we're using comprehensive behavioral intervention for tics. The joke is, yeah, just do something else. That's our treatment. Like instead, when you feel that urge, like just do something that blocks it. So in the psychology world, we have jokes about ERP essentially can be boiled down to do the thing you're afraid of. The more you do it, the easier it gets. And for CBIT, I would be like, just block the tic, just block it. That's all we're really doing. And we have fancy words because that makes people buy in and think that we're doing, like if we just said, just block it, people aren't going to pay for research studies and take us as seriously. But yeah, and the joke for behavioral activation is it's just do it therapy. It's Nike, just do it. This thing you don't want to do, we're just going to do it. So a lot of these things sound much more fancy and complicated than they are, and at their core, they're really not. So to not be intimidated by this, I think seeing someone with tics, really severe tics, can be intimidating. You're like, I don't even know what to do here, and it doesn't have to be. And to know that it doesn't have to be this, like, oh my gosh, I'm, doing some sort of medical intervention. I'm like, no, we're just gonna find out, like, when you do it, what it feels like, and then maybe block it, is essentially what it boils down to.